is Graham Silsbury. I'm a bereaved carer. I've also been involved as a lay member of a research team looking at hospice at home service.
My name is Claire Butler. I'm a palliative care physician of many years' experience and also a clinical professor at the University of Kent. This video may be of interest to anyone, but in particular we're hoping that it will be helpful for people who are considering an end-of-life situation, either facing their own end of life or caring for or supporting someone else who's facing the end of life. I'm just going to summarise what we've talked about so far, Graham. I think we've discussed how people reach a diagnosis and an understanding that they're now looking after or are themselves in the end-of-life phase and dying and at home is their preference. We've talked about the communication and the understanding that needs to happen in the home between the people in the home and also healthcare professionals, and also about what we call advanced care planning, everyone's wishes and preferences being understood as widely as possible. And we've also talked, and you've talked very helpfully, about what the carer is actually taking on in this sort of situation. I think now we should move on to thinking about what services are available to help and support in the home at this time. And it might be useful just to start off with, if you can remember how you accessed help and support when you were facing this situation with your wife a number of years ago.
Our original contact was classically through the GP, and I think that's how most contacts will be made. It's really helpful when your GP is very supportive of the situation. I think that's important. And also fair to say maybe that, you know, some GPs find it very difficult with people to say, yes, you've got this right. You know, you are in fact on that end of life journey. Yes. So be prepared for discussions about that and share those discussions that you will have already had with the person that you are needing to care for. Yes. And then referrals into hospice services, if that's then appropriate at that stage. Yes. But that will be part of the discussion. And if it's not appropriate at that point, then what point will it be appropriate? You can ask those sorts of questions. That demonstrates your commitment to want to know. Yes. If you don't feel you can ask the questions, then you're probably shying away and you ought to re-examine some of the decisions that you think you might have already taken about caring going forward. Yeah. So be upfront with yourself, honest with yourself, and ask for that support and information. Yes. And that support was given to us through the hospice services. Yes. And treatment was very, very helpful. And then the discussion, of course, was how much of this can be delivered in the home environment. Really useful times and inspirational that that opportunity was going to be given to you to manage in the way that you'd chosen was the route for you.
So, in other words, that the support was available for you to care at home.
Absolutely.
Yes, I think an approach through general practice is going to be a very, very common starting point for people and an access point. And the GP, as Graham has described, then has the opportunity or the ability to refer to a wide range of other services which may get involved, depending on the timing and on the needs at the time. And those services will be community nursing services, so district nursing services, the local hospice, who may or may not also include a hospice at home service. And often hospice at home services are linked to hospices, the physical building, but not always. So sometimes they are freestanding services. And these services vary considerably from one area to another around the country. We are not able to give you an absolute template for what the service in your area will look like because they vary. But the combination of your GP and the community nursing services will certainly know what the local landscape in your area is. We should also talk about social care. So social care is available, and you can indeed request a carer assessment from your local adult social services department in the local council. And this might be the place where we clarify that services are provided predominantly to the patient, to the index person. But we know from our research into hospice at home that the most successful care at home happens when services are also paying attention to the needs of the carer as a separate, as well as a together with the patient unit. And you've really indicated that, Graham, already in what you've said.
Yeah, that practical support into the house is absolutely critical, and therefore social services involvement in that assessment is critical. If you're able to discuss in advance of what the prospects of the changes that you're going to have to be facing will be, that is really invaluable to recognise that, because then notice can be given of intention and you're not in crisis management mode where things have happened quickly and you're not ready for that. You know, will the person that's being cared for need to come down the stairs eventually and be accommodated down there? Will they need lifting aids, hospital beds, commodes? All those sorts of things, again, are part of the journey, part of the things that need discussing and planning for.
Yeah, so community nursing will give a lot of advice about care and equipment, but as you indicate, Graham, it may be that occupational therapy, physiotherapy will also be involved, and physically equipment services who can be activated by a number of those different professional groups. Let's talk a bit more about the carers, and I think it's sometimes not clear, and understandably so, that nursing colleagues in the community have certain roles and functions, and carers, so healthcare assistants or caring staff, have different functions and responsibilities. They may overlap, and they often work together in teams. But in terms of district nursing, community nursing and hospice nurses will often deal with symptoms, symptom management, advice, with medications, whereas caring staff will be dealing with some of the very practical stuff, which is so critical at this time and increasingly critical as the patient deteriorates. So that is the moving, the handling, the turning, the cleaning, the mouth care. And as we know very well from our research, also a lot of the emotional support day by day.
Yes, that's absolutely right, Claire. What needs to be undertaken by all those people involved is the entirety of care for the person, and therefore the responsibilities are shared and often they're crossed over. So that's all about that agreement again that you have in the group of you that are involved, and the patient, of course. So the opportunity that the carer has is to provide whatever service they feel that they're enabled to do, that they're capable of doing, and supplying a quality of life. It could be mouth care and turning and washing, and you might need to be trained to do those things, and there's nothing wrong with saying, I would like to do that. Is it possible for me to do that? Can you show me how to do that?
Yes.
And that's a perfectly reasonable thing to do. It could be as simple as having that time with the person that you're looking after to read to them and giving them the things that they can no longer do for themselves, that has got very little to do with the medical care, as it were.
Yes.
You're just improving life. You're getting the best out of the time that you've got.
Yes. So, I mean, one question that obviously arises out of this discussion is how is all of this coordinated?
Yes.
Because we're talking about receiving services potentially from a GP, from a community nursing service, possibly from a care agency who may provide carers, sometimes from a community hospice service, which may or may not be enhanced by something called a hospice at home service. And it's often the case that you may well get the care that you need. We hope that you will get all the care that you need, regardless of these organisational boundaries. But it can sometimes get quite complicated.
Yeah, it certainly can, and that's one of the big issues for the carer. They seem to take the lead in this and try and work out which service is the right service to contact.
Yes.
We talk a lot about the desire to just have one point of contact because of the enormity of the busyness that's going on around the situation. Sometimes that's possible and you'll be advised where that is. Other times that's not possible. You just have to persevere and give yourself the space to do that. The ratios of the impact from when you were initially with your GP through your district nursing, they change as the journey goes on. So the amount of involvement towards that end of life journey, that last phase, we hope that the hospice service will be dominating that phase for you and caring. But nonetheless, you might still be getting visits from district nurses and social care providers, as well, of course, your family coming in more and more. As this point in your life approaches, there's almost like an upswelling of emotion that drives people to want to be involved.
Yes.
And that's something that the carer, again, has to start really to control and manage.
Yes.
And not allow it to have an adverse effect on the balance of the situation.
Excellent. Thank you for describing that so well. So hospice at home services particularly, which was the specific focus of our research together, come in all shapes and sizes, and to put it mildly, around the country. They all vary. They have been set up usually with the objective of supporting someone to be cared for and to die at home. That is their focus. As we've said, they may or may not be run through a local wider hospice organisation. Their staffing varies. They may have registered nurses on their staff and healthcare assistants, a balance of the two. And they may well have access to a range of other services within the wider hospice organisation, such as counselling, social work, therapies, etc. And I think, as Graham has already described, as death approaches, it's more and more likely that the hospice at home service, if you have one in your area, because not all areas are covered in exactly this way, will become more and more the lead service and may take on some of this role of coordination that we've talked about. But this will vary, and it's all about the communication, keeping the communication open and frequent as far as possible. Now let's think now about how you get hold of who you need to get hold of when you need them. Graham's alluded to a single point of access. So some areas do run what is known as a hub or a single point of access. So they will aim to have one telephone number for you to contact in these circumstances. And then the person at the end of the phone will then decide what service you need and triage accordingly. Not all areas have that. And you may find that even if there is a single point of access, it doesn't operate 24 hours a day, and you have a different arrangement overnight. So this will be very much locally determined, and we may end up with a list of telephone numbers of different people to contact at different times of day and in different circumstances. And this is a heavy task for the carer to take on sometimes, particularly if an unexpected or emergency situation arises. Who on earth do I ring?
That's a very good point, and often is a real burden on carers to know just who to contact and when to contact them. The important thing, I think, from a carer's perspective is to recognise that whoever you're contacting has got a professional responsibility to help you resolve your problem. So the key thing is to be very clear about the issue that you believe you're facing, why you're making the contact, and why you phoned them preferentially. And if that's an error and it needs to be somebody else that you're talking with, they will advise you on that, have that discussion. They will be obliged to
Direct
do that.
you, yes.
Yeah.
And I think it's probably useful to say that if you end up calling a very general service like, say, 111, to put the context of your situation to them immediately. So I'm caring for X, we're under the hospice, the wish and preference is to die at home, and we're asking for help with X. Because otherwise, sometimes we have come across people whose loved one is unwantedly sent into hospital in these sorts of unplanned situations. So it's all about, as far as you can, in a very difficult moment, giving the background to reassure health and social care professionals of what we're asking them for. And we're not asking them for urgent and interventional care. One of a whole range of issues that will be of concern to people at this time is financial, money.
Yes.
And how they're going to pay for care, if that's required, where financial support and advice might come from.
Yes.
Do you have anything you'd like to say about that, Graham?
So benefits are available. Whether or not you're entitled to them will be a matter of how you are placed financially.
Sure.
So it's an area that you need to, again, ask the questions about, whether it's something that you can apply for. As we've already said, this again puts a burden on the carer because it's more work to be done, when actually your primary focus, of course, is the care. You've then got to find that space. Opportunities will come about as your applications are made to see whether, if you're entitled to one allowance, that opens up the gate for other allowances.
Yes.
So it is a journey in itself.
Yes.
You could use citizens' advice in this regard. Your GP will be able to give you a certain amount of information. And of course, with modern technologies, you can make your own inquiries about what the government is going to see as being appropriate for your circumstance, simply by doing searches.
Yes.
So these are opportunities now where you can find out. You can do a lot of research yourself without having to make those contacts. But don't be afraid to ring your council.
Yes.
Rates relief is another thing that will be appropriate, and there are also emergency allowances towards the very end of life. If you're in that financial, that shouldn't be your ultimate concern, should it? It's such a shame when you are at that point in this journey that you're still worried about finances.
Yes.
So again, just appeal to whoever you've got, and very often the professional people coming into your home have that discussion, because they will have had that experience before.
Yes.
You're doing it possibly for the first time.
Yes.
They see it all the time.
Absolutely right. So yes, take advantage of advice from people who are visiting in the home. Adult social services are based at your local council, and as we've said already, will provide a carer assessment as well as advice about finances and benefits. If you are involved with a hospice service, they very often have social workers employed as part of the team who can also offer advice and support in this. I think so there are sorts of things that you will hear about are attendance allowance, and also I think it's worth specifically mentioning continuing healthcare funding, so that at a point in time where you or the person you're caring for need a lot of physical care, lifting, turning, cleaning, toileting, etc. And you need people coming into the home to help with that. That sort of care may be provided through care agencies in the community, and at a certain point in time, depending on your own financial resources, you may have to pay for that. But also at a certain time, once it is deemed or it is decided that the healthcare needs of the person you're looking after are dominant, then there is a funding stream called continuing healthcare funding, which will then take over the payment for personal care. And so that's something to be aware of and to ask about. Am I, or is the person I'm caring for, eligible for continuing healthcare funding? And the other buzzword will be attendance allowance. That's another means tested allowance that you may well be eligible for at this sort of time.
So Claire, it could be that in this financial situation that people are going to find themselves in, when they do engage with hospice services, they'll be worried about payment of that.
Yes, I think that is an anxiety for people, because I think people are aware that the majority of hospice care in England is provided through the charity sector, and that also applies to hospice at home services. To my knowledge, there is no hospice service in England that charges. All of these services are funded through charitable donations and fundraising, and provide care in exactly the same way as the NHS, which is free at the point of access. So there will not be charges from your local hospice. It begins to sound as though your home could get very busy during this time.
Yes, it certainly can. And you're entitled to actually manage that situation. It might be something that you're actually accepting of and finding it all very useful and constructive. You may want to plan your day in such a way that you're prepared to have that input from third parties, wherever they're coming from, over a period of time, but then you might want to say, we want quiet time after so-and-so, whatever so-and-so is. Respecting, of course, that the situation that you're dealing with is also subject to change.
Yes.
A crisis might happen and you might have to break the rule that you've created for yourself and change again. But it's something that can be managed, needs to be agreed as being practical and appropriate. So if that's something that you want to have, if you want to set up a specific part of your house, for example, to look a bit like a hospital wing, that's fine and might be a very practical thing to do. Have all the equipment in a particular area, but you've got a great opportunity to also personalise that space, haven't you? So that the patient feels that they are genuinely at home and surrounding them, because that ultimately is their wish. That's where they want to be. So let's not change the environment to the point where it might just as well be a hospital.
Yes, good point. I think one of our researchers had a lovely story from interviewing about a couple who said, we just need a bit of time in the evening when we don't have carers and help coming in and out of the house, because that is when we are husband and wife. I realise that we may not have answered all your questions. One of the things we've not been able to do is to specify exactly what services will look like in your area or what the points of contact might be for you. And that is because services vary so much around the country and change over time.
We hope you found the video helpful and supportive, and please make real good use of your local services.